morning, everyone, everywhere. So we have people online. So unfortunately, we had to cancel the visit of Virginie at the last minute, but we have people at EPFL, people at CHUV, and other people online. So it's a multi-centric meeting today. So it's my pleasure to welcome everybody to this new 70 MRI seminar. So the talk of today will explore the exciting advancement and challenges in spinal cord imaging at ultra-high field. And we are pleased to welcome Virginie Callot. So Virginie is the research director at CRMBM, which is the Centre de Résonance Magnétique Biologique et Médicale at Aix-Marseille University. So where she leads the Spinal Cord MRI research group. So she has a background in physics, and during her career, I'm impressed to see that she has worked on a diverse range of MRI application, including hyperpolarized MRI, cardiac diffusion perfusion, and brain tumor characterization before focusing more on spinal cord. So in today's talk, Virginie will share insight into what is currently possible with spinal cord MRI at ultra-high field, the opportunities it presents, and also the challenge that remains. So welcome, Virginie, and we are very happy to have you with us. And so the floor is yours.
Thanks again, Frédéric, for the introduction, and thank you all, especially Emily, Dimitri, and Francesca for the organization. As it has been mentioned, I was supposed to come to do some tests in Geneva. Unfortunately, we have to cancel that due to a problem on the scanner. But I really would have loved to be here with you to discover CIBM and Lausanne and Geneva and so forth, but well, some troubles can happen on the scanner. I just wanted to show this picture that we have taken 2 weeks ago. Our system was also in trouble, so well, it happens. And well, I hope I will come soon in Geneva and be able to meet you all in person. So as it has been mentioned by Frédéric, I'll try to give you an overview of what we can do at 7 Tesla to image the spinal cord. It's mostly feedbacks from our site, and I'll try to show you what we can see, the progresses that have been made over the years, and what are the issues we still face. A brief introduction about the lab, if you don't know us. So the lab is composed of 2 entities. So it has been mentioned by Frédéric, CRMBM on the medical school of La Timone, and CNRS directly on the hospital. CRMBM is affiliated to CNRS, le Centre National de la Recherche Scientifique, and Aix-Marseille University, and CNRS affiliated to the Assistance publique des hôpitaux de Marseille. And in the lab, generally speaking, we work on MR methodologies, mostly focusing on pathologies in the cardiovascular system, musculoskeletal system, and central nervous system, so brain and spinal cord, and we will focus on that in a few minutes. And we have different equipment for fundamental research on animal models, as well as clinical research on human pathologies, very low field and very high field at 7 Tesla. In the group, we are interested in methodological development for quantitative MRI, as well as some post-processing tools and their application. So from preclinical research, although it's clearly not the main focus anymore. Now we are mostly focusing on different pathologies, neurodegenerative and compressive pathology affecting the spinal cord. And we are in close link with our colleagues from the biomechanics through the iLab Spine International Lab between France and Canada. So having said that, well, we will switch to spinal cord. Being in Lausanne or Geneva, you should know a lot about spinal cord, I think. It's just the main pathway to convey the information between the brain and the rest of the body. It is composed of white matter, gray matter. We are interested in these two substructures because they contain the nerve cells of bodies and myelinated axon. And this spinal cord can be impaired by biomechanical causes, such as spinal cord injury or degenerative cervical myelopathy if the intervertebral discs are impaired, and also neurodegenerative disease such as multiple sclerosis. If you have a lesion or if you have an injury, then you have a cascade of events at the structural level, vascular level, cellular level that will cause different deficits up to a very severe handicap. And when you have a neurological deficits, diagnostic is made using conventional MRI at 1.5 or 3T, using T1 weighted, T2 weighting, and so forth. You can see the signal abnormalities, the location, and the extent, but usually you don't have information about the underlying impairment that occur in the tissue. So this is why we are looking for some quantitative parameters and try to identify some new biomarkers that could help for the prognosis or to evaluate objectively the therapy. At 3T, you have different techniques, and some of them have been recently standardized, so for morphological measurement, diffusion, transfer, magnetization, for instance. And the other ones are mostly still at the stage of clinical research, such as relaxometry, myelin water imaging, fMRI, etc. And this technique usually have a resolution of about 1 millimeter, and they suffer from low sensitivity. And if you want to target specific tracks, or if you want to look more closely within the gray matter, then high field, ultra high field 7 Tesla MRI can be very interesting, of course. So just to maybe to look back on what is the history of ultra high field spinal cord MRI. So everything started in 2009. So something like 10 years after the first report of brain MRI. And then progressively you had different reports for high resolution, CEST, fMRI, spectroscopy, etc. in the spinal cord. Only very recently, PTX application and also universal pulses application in the cord. It's reports mostly just to explain that clearly we lag behind brain MRI at ultra high field with spinal cord. If we look at the number of papers that have been published in this field, less than 50 papers coming from not that many institutions. So here it's a report indicates 16 institutions, but indeed it's only something like 10 groups that are very active in the field. So Geneva is going to join us. This is wonderful news. Why is that? So why is it? It's more than maturating, it's an expanding tool right now, but still there are not many people, and there are different reasons for that. Some challenges related to spinal cord MRI. I will briefly mention that just in the coming slide. And there was also a lack of available dedicated coils related to the smaller research community and potentially the lower demand. So concerning the challenges, some of you are already aware of that. Spinal cord MRI is not simply brain MRI. Brain can be seen as a ball, homogeneous ball, but spinal cord is completely different. You can see spinal cord here as compared to the brain. So a very small cross-sectional area. It's mostly like my little finger for the diameter 7 by 12. If you look at these images that has been acquired at 7 Tesla, you can see the cross-sectional area for the cord is less than 1 centimeter, and for the gray matter, it's less than 13 millimeters square. So very tiny structure. We need some millimetric resolution. it's also a curved organ. So if you want to discriminate white matter, gray matter, you have to deal with acquisition slices that are perpendicular to the curve. And it's also a long tubular shape. Just for the anecdote, it's the third longest organ in the body. So usually we only work at the cervical level when we do a quantitative MRI. We also have linked to this long shape B1 effect, of course. At 7 Tesla, we'll talk about that later on, but in average, at the lower level of the upper spine, we have something like minus 30% in the B1 efficiency. And then you also have to deal with an inhomogeneous environment due to the presence of the bone, the intervertebral disc. There are some strategies for that. You can deal with the local shim, you can do distortion correction if you deal with gradient echo and EPI sequences. And for the pulsatility, depending on the type of sequence, you can use synchronization with the physiology, ECG or pulse oximeter, for instance. And you also have the presence of the lung that creates some B0 dynamic fluctuation. And again, your signal can be disturbed by that. And there are some ongoing initiatives to correct for that, or some strategies, but it's not a push button on the system. And as mentioned previously, there has been for a long time a lack of spinal cord dedicated coils, and so related to the smaller research community and the demand, but also the challenges related to the design. So here it's a picture from Bob's Berry review in 2018. You can see different design. It's mostly surfacic coil. So we have this design in the lab, and more recently, we have this kind of design, so with posterior and anterior element. Also, a channel that has 16 transmit elements, so very interesting, but not available everywhere, of course. And these were mostly for cervical imaging, and you have also some design. Mostly prototypes for the thoracic and lumbar level investigation. And in the lab, we use this prototype. So altogether, I think that, and one message here is that we still need a very efficient and affordable coil. And we also need coils that could be compatible with an examination of the complete cord. So if you want to do an examination from cervical to lumbar level and you want to avoid to switch the coils, well, you cannot do that right now at 7 Tesla. So having said that, what can we do? What can we see? As mentioned, this will be mostly feedback from our site. So in Marseille, we started with a magnetum system. We have now a Terra system, and I hope at some point we will have a Terra X system. We are equipped with a rapid biomedical coil. So you can see the design here, a surfacic coil with a saddle shape. There are 8 elements. At that time, it was a prototype, but it's now available for Terra and Terra X system if you order a Siemens machine. Currently, it comes with a power splitter that combine all the elements so that you can use in CP mode, but it has, of course, the possibility. You have the possibility to perform parallel transmit. I will talk about that later on. So it's kind of comfortable, but it's a simple design, I would say. You can put some cushion just to avoid motion, for instance. And as mentioned, it covers cervical cord, and you have some B1 penalties. You can see that here on this B1 map, and you can see here some numbers. So this is C1 level and C7 level, and you have a drop in the B1 efficacy. So depending on what you do, you may have some penalty or some SNR loss on your images. And this mostly depends on the morphology of your subject, of course. So in the lab, we are mostly interested in morphology, high-resolution structural MRI, as well as perfusion and spectroscopy. So I will give an overview of that. And I will start with morphology, with some 3D isotropic images acquired with the T2 space sequence, as well as with the MP2 range sequence. And I thought that these images could be of interest for the people in Geneva, because you can see the spinal nerve rootlets, and this could potentially help for the anatomofunctional localization of these nerve rootlets and the spinal levels. And for the people working on neuromuscular disease, maybe it could also be interesting to see these rootlets and eventually see the impairment or degradation of these roots with some pathologies. So it's old images. At that time, it was a resolution of 0.7, 5 minutes acquisition or 9-minute acquisition. But now with the compressed sensing, I think you can accelerate the thing and get pretty good images with a shorter acquisition time. So our interest in the lab is not really spinal rootlets or fMRI, mostly morphology and structure. So we worked with other sequences, such as the multi-gradient echo image with very high in-plane resolution. This is an example with a 200 micrometer spatial resolution. So this is native resolution, and if you compare with the images we get at 3T, well, you can clearly appreciate the possibility of delineated white matter, gray matter. You can see the dura mater, again, the nerve roots, ligaments. And if you want to target some very specific abnormalities in some pathologies, then it could be very useful. This is an example in an ALS patient, amyotrophic lateral sclerosis patient. So in this patient, you have a motor neuron disease degeneration or death, and subsequently you have degeneration of the lateral corticospinal tract. And what is interesting here is that you can also see that there is a degeneration of the anterior motor tract. So this has never been reported, and it was not seen on 3 Tesla, mainly because of the spatial resolution, of course. And these resolutions are also very useful in the case of multiple sclerosis, because you can now target smaller lesions that were not visible at 3 Tesla. So you have here an example with a very small lesion here on the outer edge of the cord that could be seen so at 7 Tesla, but that was missed at 3 Tesla. And it's also an opportunity to refine your measurement in cross-sectional area for the white matter and the gray matter, because these measurements are a well-known biomarker of atrophy. So this can be useful in MS or in other neurodegenerative pathology if you want to have a more precise follow-up with your patient. In routine, we don't work with this very, very high resolution. We mostly work with a resolution of 300 micrometer with multi-slab acquisition, and you may have some penalties depending, again, on the morphology of your subject or the number of slices you want to cover. You may have some penalty with a specific absorption rate. This is one of our main issue working at 7 Tesla on the spinal cord. Sorry, can be very limiting. So this was for morphology, and we have also some interest for other quantitative approach, I would say. One of them is T1 mapping using the MP2 range sequence. So in Lausanne, you know it pretty well, I think. So it's a non-specific sequence. T1 measurements are non-specific, but they are sensitive to myelin degeneration, iron deposition. So they are of interest in neurodegenerative pathologies. I'm pretty sure you use that commonly on the brain. So just a brief reminder that thanks to 2 volume acquired with 2 inversion times, and you can have a combined mixed image, uni weighting, and you have thanks to a lookup table, then you can have an access to a T1 measurement. Well, you just have to acquire a B1 map to correct for your B1 inhomogeneity and retrieve some unbiased T1 values, although T1 is not is always biased, but at least it's not biased anymore by B1. We use that a lot at 3 Tesla, covering brain and upper spinal cord. At 7 Tesla, you only cover the cervical cord. At 3 Tesla, it has been demonstrated that it's very robust intersession and also in a different center. So we really like and we use this sequence a lot. It's just an example where we have demonstrated, still at 3T, that we have an improved lesion detection using the MP2 range as compared to the Magnim's sequences, so mainly T2 and STIR sequences. So you detect more lesion, and you can also have access to the diffuse impairment occurring in the tissue. You can see here the LC control as compared to the multiple sclerosis patients. It's a mean map, but you can see here increase of T1 showing a degeneration of the tissue. So of course we were interested to have this sequence at 7 Tesla as well. We started with a generic protocol, I would say, with a 0.7 millimeter square cubic resolution. And with these sequences, well, we were able to detect again the lesion, of course, because they are associated to a very high T1. And we have conducted a more careful analysis again in MS patient. It's a small cohort, 20 patients, but again, we were able to show that there is an advantage with the MP2 range, and comparing the MP2 range at 3T and the MP2 range at 7T, well, we have demonstrated that with 7 Tesla system and the high resolution, it's very logical, but with the high resolution, you have an increased conspicuousness for MS. So diagnosis usually in MS is already addressed, so it's not really a big problem. But if you want to detect new lesion during your prognosis, then it could matter, and this could have an impact. Or if you are looking for a single lesion in the spinal cord, then 7 Tesla system can help to detect that. For us, it's also an opportunity to look at new substructure within the spinal cord. So we have now a protocol with very high resolution, 0.3 millimeter in plane. And now you can see some substructure within the gray matter. You can nicely see the dorsal horn of the gray matter. You can also see central canal, septum, and anterior fissure that were not visible at 3 Tesla. Here I just give an image of what we have currently with the MP2 range with a resolution of 0.9. So clearly now you can really see what happened within the gray matter with some maybe some cluster corresponding to the motor neuron position and so forth. Not motor neuron position, but motor neuron cluster. And again, it's new opportunity to refine the characterization of spinal cord, especially within the gray matter. So here it's just 2 examples, LC control on the top, MS on the bottom, and you can clearly see here a lesion within the gray matter. So again, it's new opportunity to try to study the gray matter involvement in MS. There has been a lot of studies in the cortex with these gray matter lesions, but in the spinal cord, it's also very interesting. And another example that I really like to show, you can see here in this patient strong impairment in the dorsal tracts with demyelination in this tract that is related to the inhalation of nitrous oxide. So there is a perturbation of the metabolism that creates demyelination. So it's really beautiful images, but well, not that funny for the patient, I would say. So I talk about T1 mapping, relaxometry. We use that a lot. Something else that I could mention is diffusion. So clearly, diffusion at 7 Tesla on the spinal cord, being at 7 Tesla, you don't expect a lot. It's not, especially if you have a Prisma system, for instance, that's really because you can expect higher B0 inhomogeneity, you will have higher SAR, but in our case, we wanted to have all our protocol at 7 Tesla to avoid 3T exam in addition to 70. So we work on diffusion to try to optimize it. You can obtain decent images. This is an example with a spatial resolution of 0.8, so what you can have at 3 Tesla. So just with a single shot Spinnaco EPI, basic B0 correction with a local shim, and also phase and reverse encoding to correct for the distortion. So it's kind of okay, and you can also go to higher spatial resolution, knowing that you will be limited by SAR, but still. And this is an example with a spatial resolution of 0.4 millimeter, and it's interesting because you can start to really discriminate the different tracts, but you can also see more within the gray matter again. And this is an example where you can see crossing fiber within the gray matter. I mentioned that it's really a basic level B0 correction with a local shim located around the spinal cord. But you can see on the B0 map here that you still have some heterogeneity for the B0 field. So if you really want to correct for all the distortion and things like that, you may have to go for a more advanced correction like Z-shimming, integrated shimming, shimmer array, and for the strongest effect close to the lung because of this dynamic B0 fluctuation, then you may have to go for offline post-processing as described in the paper of Johanna Van Eschow a few years ago. But this level 1 and level 2 are not, again, not push button on the system. So just for you to be aware of that. For us, diffusion was an opportunity to study or to study again perfusion. We had a strong interest in perfusion because when you have a compression of the cord, or if you have a spinal cord injury, then you have a dysregulation of the perfusion. And it's important just to have the viability of your tissue. We used to work a long time ago on that in mouse models using an arterial spin labeling sequence, where we demonstrated that it is possible to map the spinal cord blood flow. You can see here the blood flow within the gray matter. And it's interesting because if you have an injury, you can see the ischemia, and after that, if you follow your mice, then you can see an hyperperfusion that is related to angiogenesis. So clearly there is a clinical interest for that. Unfortunately, arterial spin labeling in human is really, it's hard to implement. You have low CBF, you have the B1 inhomogeneity, so inefficient blood tagging. So this is where diffusion could play a role, because you have the intravoxel incoherent motion. It's a very old technique that was proposed by Le Bihan, but we have reinvestigated that for the spinal cord. So it just took a compartment. It assumes that there is a vascular compartment and that there is a random motion at the capillary level. So you can assume you have a pseudo diffusion, and with acquisition of very low B values, then you can have access to this vascular compartment. And here is what we get at 7 Tesla. So perfusion indices maps, it's not really spinal cord blood flow, but it's vascular fraction and velocity within the grammater. And you can see here higher perfusion indices within the grammater. It's what we expected. The grammater is more perfused than white matter. But what is shown here is average maps across different subjects. So we are not yet sufficiently robust at the individual level in a clinical compatible scan time to apply that routinely in our patient. But nonetheless, if you have time, if you can spend 40 to 45 minutes, then you can apply this method to get perfusion measurement. And in Balgris Hospital in Zurich, so Marianne Seif and Patrick Freund have applied this technique at 3 Tesla on people suffering from degenerative myelopathy, and they were able to demonstrate that there is a perfusion impairment beyond the site of compression. And they also applied that in spinal cord injury and demonstrated that there was above the injury again perturbation of the vascularization. So it's this was at 3T, but it's also of course possible at 7 Tesla. Just a question of having the time to apply this sequence that is not very sensitive. So yeah, you need time. And it's also to show that what we propose at 7 Tesla can be back propagated at 3 Tesla. So for us, we wanted to have something short, so we then decided to switch to dynamic susceptibility contrast imaging using EPI sequence, again, gradient echo and spin echo. So it's with gadolinium injection, some strategy to synchronize everything with the physiology, and we providing adequate post-processing with motion correction, respiratory filtering, and so forth. We were also able to collect perfusion maps. So this is a relative spinal cord blood flow. Again, we were able to see that gray matter is more perfused than white matter. But if you deal with gradient echo, you are very sensitive again with the dynamic B0 fluctuation that occurs, and since the signal coming from perfusion in the spinal cord is very low, then you are contaminated by this B0 field variation. And if you deal with spin echo APIs that are less prone to this dynamic B0 fluctuation, then you have SAR issues. So it's not yet applicable in the clinics. We are still working on that to manage the SAR and also to work with other readout modules. To complete this, because we are interested by various methodology to try to characterize as much as we can the different pathophysiological mechanism. We were also interested in metabolism, and we expected a lot from 7 Tesla. Because, well, thanks to the spectral enlargement and the SNR, you can hope to be able to see small metabolites, especially glutamine and glutamate, that are indicative of excitotoxicity in the tissue. So here it's an example of what you can get in the brain with the voxel size is something like 15 millimeter cubic. In the cord, well, you have to deal with a smaller voxel size. The size is about 4 to 5 times lower than for the brain. So it's small rectangle, and you are lucky if your subject has a straight cord. So, of course, lower signal. And again, you are subject to this B0 dynamic fluctuation, even at the upper level of the cord. So you can see here some spectra that have been acquired, and you can see in blue here the variation of the chemical shift that is superimposed with the signal coming from the respiration. So clearly, you have a shift, and you have to deal with that. So Tanguy in the lab has worked on a respiratory triggered approach and a post-processing approach to deal with this effect. And here are the spectra you can collect. So you have an improved SNR for the main metabolites like N-acetyl aspartate, creatine choline, and decrease coefficient of variation, but we cannot measure confidently the small peaks that we were expecting for our pathology. So this was a bit disappointing, but I think that for the people working on maybe some spectral editing or other approaches, well, there are still a lot of things to do, and maybe PTX could also play a role so that we can prescribe a voxel that is just cylindrical and that match with the cord morphology of the subject. I will just say a few words about fMRI because I'm not working at all on that, and people on the group of spinal cord in the lab are not working at all, but I know that you do, so just a small feedback on that. People in Vanderbilt, Robert Barry, for instance, have shown that we are able to study the connectivity in the spinal cord using resting state functional MRI. Sorry. And they also applied this methodology in MS, where they demonstrated that there is a disturbed functional connectivity related to the presence or absence of lesion. And this is a more recent work from Alan Seifert in New York and Johanna Van Eschow, where they compare different readout modules, so single-shot EPI versus segmented EPI, and well, they study the advantage and disadvantage of each of the sequence for signal activity, the signal you can retrieve, the activation, and also the spatial localization of the signal. So it's still ongoing. You really have to deal with this dynamic behavioral fluctuation again. So again, I'm not on that, so I will not talk too much about that. Just a few words about clinical transfer. So I have presented different approaches: morphology, relaxometry, diffusion. I talk about metabolism, perfusion, and fMRI. Among all these sequences, 3 of them have been identified as ready to be pushed for the clinics. And we have performed a quality assessment from ugly to good images, success rate for each of these sequences in different cases: LC control, MS, degenerative pathology, and ALS. In all the cases, T1 MP2 range performed very well. DTY is not that bad, and the MGE sequence, multi-gradient echo, as said, the sequence suffered from this dynamic behavioral fluctuation in the lower level of the cord. So the results are maybe a bit more mitigated, but still, well, these results are very encouraging. And this sequence has been pushed in Balgrist Hospital, so it's a close partnership with Marianne Safe again. And we have edited some guidelines, and they will be soon available on GitHub. And these 2 sequences have been modified for a specific purpose of spinal cord, because by default, the sequence provided by the vendor is not strictly applicable for the spinal cord. So these sequences are available on the TeamPlay platform for different versions, Magnetom, Terra, and also XA1660 for Terra X system. And based on that, we have conducted a multi-centric evaluation with different centers. So currently Zurich, Montreal, New York, London, Leipzig, and Trondheim. And you guys are part of the newcomers, and we will soon start the acquisition. So 6 centers and 4 coil design, and we had 3 subjects that traveled on each of the center, and there has been a reproducibility study. In this study, there are 3 arms. One is for fMRI, led by Alan Seifert, one for coil QA, led by Eva Alonso, and Marianne and I are in charge of the spinal cord quantitative MRI. Here, I just show some results. So for two subjects, subject 1 on the top, subject 2 on the bottom, in the different centers. Here's a flip angle map or P1 map, MP2 range acquisition, QT1, quantitative T1 maps, and T2 star acquisition for the morphometry. And you can see that for some center or some coils, well, it was not possible to perform the protocol. Altogether, so 4 center and 3 coils have demonstrated that we can have a very good reproducibility among the different subjects and the different centers. I will not go through that. This will be presented at next coming ISMRM, but just to let you know that we have some robust protocols that could be played right now. I will briefly talk about post-processing because we collect a lot of quantitative data and you have to post-process them. And as mentioned, we have a strong interest for some specific substructure within the spinal cord. So usually, if you are at 3T, you have in your pipeline, you segment the cord, you segment white matter, gray matter, then you co-register everything to the PAM50 templates. It's one approach. You can register to whatever, but you have this template in the Spinal Cord Toolbox. But with 7 Tesla images, you may be in trouble because you have higher resolution, you see more details, you may have some signal loss in some area, so the cord segmentation may fail. So this is one point. And then you collect very high resolution images, 0.3, 0.2 millimeter, and so there are no point to register to a template that is 0.5 millimeter, that has a 0.5 millimeter resolution. So we work on these 2 approaches. First, a multi-class model to train our data and be more robust for the segmentation. And you can see the results we get now with this model as compared to the conventional approach on the Spinal Cord Toolbox. This model is now available on the Spinal Cord Toolbox, so you can just have a look if you want to try that on your data. And we are working on similar approaches for the T1 contrast. And for the template, we have built a new template, the MU7 Tesla MU70 template. It's also available on Spinal Cord Toolbox now, and this template has more parcel, especially in the gray matter. So this could be relevant if really you want to study pathologies focusing on motor neuron, or if you do fMRI, if you want to target some specific area within the dorsal horn, then this protocol may be, this template may be relevant. And in collaboration with Neuropoly, we're also working on the automatic segmentation of the lesions. They have worked a lot on 3 Tesla data, and we are trying to tune the model to be able to confidently segment the lesion in MS. And this will be presented as well at the next coming ISMRM, and the model will soon be available on the Spinal Cord Toolbox. So many post-processing tools. So I try to wrap up everything. So you have different methods that can be applied. I didn't talk about CEST. We don't do that, but in Vanderbilt University, they used to do that. At least there is one report. So for the cervical level, you can do most what you want, I would say. Some of these techniques are currently tested in multicentric approach. At the thoracolumbar level, there are not that many reports, only morphological report. So I would say that we are still in the use of 7 Tesla Spinal Cord MRI. It's not FDA approved yet, to the best of my knowledge. You have dedicated post-processing tool. The RF coil designs are currently in improvement to cover brain and C-spine or thoracolumbar levels. There are also some approach to correct motion and dynamic fluctuation. One issue we have working on CP mode is SAR, specific absorption rate, as mentioned. B1 heterogeneity is not it could be a problem, but sometimes you can correct for that. So that's fine. But for the SAR, you really have to switch to PTX. So just a few words about that, because Aurélien in the lab, Aurélien Destruel, is working a lot of that in the lab. So as mentioned at the beginning, with the current design, with a rapid biomedical coil that you have in Geneva, you have this power splitter. You can just remove it and work with the 8 transmit channel, and then you have more flexibility to prescribe some phase or magnitude to each of these elements and try to mitigate your SAR and B1 heterogeneity. But to confidently perform parallel transmit, you need VOP, virtual object point, and they are not provided by the vendor, meaning that, well, you have to do your electromagnetic simulation, then you have to validate everything, B1 validation, E-field measurement, or thermometric measurement, and then you have to design by your own your safety margin, and then work on your tailor pulse design. So this is ongoing. The VOP for this coil should be available at some point, so we hope we will be able to share that. And once this is set up, you can then play with SAR management in your favorite sequence. I just want to mention also other initiatives. So in Europolis, they work on RF shimming. You can check this open source toolbox, and in Berlin they are currently working on a universal pulses approach. So just keep an eye on that. And since that Benedict is online, it's still the same message, but I think that most of the effort have been made for the brain. I think we also need some effort for the spinal cord current strategies. I don't know for Terra X, but at least on Terra, the current strategy for B1, static B1 shimming, for instance, are not optimal for the cord. So there are room for improvement altogether, I would say. So current landscape, very nice road, not many people on the road, beautiful things to see. Someday maybe it will be a very highway, a big highway with many people on it, but well, that's like this for now. And to finish, I would like to thank all the people working on the team. I have a wonderful team. I would like to thank current and previous people, as well as clinicians who I am working with, and the other people from the academics and the industry. And I want to finish with an advertisement. ESMRMB will occur in Marseille in October, and one day before, so it's not ESMRMB event, but one day before in Latimon, we will have an event focusing on spinal cord MRI imaging. I will advertise more on that in April, but well, save that this date on the agenda, and I hope you will join us. And with that, well, I'm all done. So thank you very much for your attention, and I hope it was not too long or too boring for you.
Thank you very much, Virginie, for this wonderful journey in the spinal cord imaging.